You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way. Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Evelyn from Nashville Fertility, and I'm joined by my fabulous, beautiful co-host, Dr. Susan Hudson from Texas Fertility Center, and Dr. Carrie Obedient from the Fertility Center of Las Vegas.
Hey, how's it going?
It is going great. I can't believe time is flying by. We're already thinking about Thanksgiving before too long. And we were just chatting right before the show. We were talking a little bit about food. So, Susan, tell us what you were saying about your favorite dish on Thanksgiving.
I think my favorite dish is stuffing because it's something that you never have any other time. Now, we do a cornbread stuffing, but I love stuffing with a little bit of cranberry sauce. And it's just a happy food, but it's a once a year food. I don't think I would like it if I had it more often than that.
I'm surprised to hear you say stuffing because I would have thought, that is a gluten-loaded.
Yeah, that's true. That's a great point.
It's not, it doesn't have to be gluten loaded. I can say my family's always traditionally done a cornbread stuffing, but all you have to do is have the gluten-free cornbread and then you make it. Just because I can't have gluten doesn't mean I don't love carbs.
That is entirely legitimate. What's yours,
What
Abby?
about you guys?
So my favorite is sweet potato casserole. It's sort of twofold. It's really yummy because it's more crispy brown sugar with pecans on the top of a little bit of sweet potato. So it's almost like more like a dessert than it is for an actual meal. Another reason, it's sort of a tradition in our family. My mom used to make it. And one of the last Thanksgivings before she passed away, she was like, I was making sure I had the recipe and she was helping me with it. And so that's just sort of a memory I have of us making the sweet potato casserole together right before she passed away the following year. So that was kind of
potatoes, because I generally make them one time a year at Thanksgiving. And part of the reason is because I'll take the potatoes and boil them and get them soft. And then once they're drained and we start mashing, I put in probably a body's worth of butter, sour cream, and cream cheese.
That sounds really good.
It's so good. And I make enough to feed an army for at least a month.
Yeah.
And we have a ton left over. And my husband and I are the only ones in the house that will eat the leftover mashed potatoes. And so it's fantastic because that's what I eat for easily a week or two afterwards. And I just shove some in the freezer and it's great.
So do you guys like leftovers? Because I love leftovers. Some people hate leftovers, but to me, that's even better than the actual Thanksgiving meal because you're like, oh, let me have more of this. This was really good. I'll have some of that.
Mm-hmm.
I am not a leftover fan.
Really?
I am not.
I love leftovers.
No, but I was going to say one of the best ways to do leftover mashed potatoes is to make potato pancakes.
That sounds good.
You put them in little patties and then fry them. Oh, those are so good. And a little bit of applesauce with it. Yum, yum,
Ooh,
yum.
That sounds good.
really good. That sounds like some sort of Lithuanian dish.
It's German. It's German.
Yeah, that
All
does
right.
sound really good.
Well, very good. We're going to do an endometriosis question episode because we haven't done endometriosis in a while, actually. And we get lots of questions about that. What we got for us, Susan?
Some of these questions are straight on endometriosis, and some of these are like endometriosis byproducts, and you'll understand why when I read this question.
Byproducts?
So the first question is, I am currently 36 years old, PCOS, AMH 3.3, AFC 20, husband is 40, moderate to severe male factor infertility. We did an egg retrieval, 22 retrieved, 22 mature, 14 fertilized, 9 blasts, 6 are euploid. Failed their first 2 FETs. Our first was fully medicated. Lining was only 5.5 after a month of oral vaginal patches and a negative beta. Our second was a modified natural, 12 extra hours of progesterone, but lining got to 7.9. However, beta was only 1. So we did an ERA, Emma Alice, and Receptiva. The Receptiva was positive, and MRI shows focal adeno. The new plan shows a modified natural FET after 2 months of Lupron, Letrozole, and Agestin. Is this a reasonable plan? Our doc has recently left the practice and we haven't met with our new RE to discuss.
I think she touches on a great point because I have this dilemma too. If you put somebody, so the treatment, if you have a positive receptiva, is to do 2 months of Lupron. But then the dilemma is, according to Bruce Leslie, who developed this, you don't want to have a period and you want to go straight into a treatment cycle, which is a little hard to do if you're going to do a modified natural cycle. I actually have had a couple of people, and I don't know if this patient would be in that category, but I've had a couple of people that have pretty bad endometriosis, and we've talked about laparoscopy, and they've done laparoscopy for removal of endometriosis, and then we've done a modified natural. So that's the way I've approached it. Otherwise, I don't know how you would do a modified natural with 2 months of Lupron.
So you do the laparoscopy instead of the 2 months of Lupron.
Right. Because when the assay first came out, you could do one or the other. And most people are like, I don't want to do surgery. But I think for some people who've had more than one failed cycle and they really think treatment of receptivity is useful, that would be a way to look at it. Other thing you could do is you could try some Lupron, retest the receptiva, and then do a modified natural. But according to Bruce Leslie, you've got to go straight into a cycle without a period.
Well, retesting the receptiva doesn't change anything. Once you're positive,
Yeah, that's true. But I'm saying if you've had treatment, though, you could do treatment with something and then go back into it and check it again. But Bruce Leslie said that doesn't work.
yeah, he said it doesn't, going back to recheck, it doesn't add anything. And since it is uncomfortable, that's less fun to do for everybody.
Considering she's had an MRI that shows focal adenomyosis, for our listeners, that means that she has endometriosis cells in the muscle of the uterus. That isn't something that's generally going to be resected from a laparoscopy. So in this case, like being treated chemically with the Lupron, letrozole, and agestin, I think is a reasonable plan. Usually I either use Lupron or I use Orlissa, but this sounds like a good thing. But you may need to change your plan of doing a modified natural cycle, or you could do a modified natural cycle. We, in our practice, will do that with letrozole. And if you can get follicular recruitment with the letrozole and doing a modified natural cycle that way, modified natural cycle means a lot of things to a lot of different people. And so that's a little bit more modified, I think, than some people, but that's what we generally do. We don't have people just ovulate on their own. We usually use letrozole for follicular recruitment and then either time it based on LH surge or with an Ovidrel trigger.
Yeah.
So for this patient, we're saying then that we think she should probably do what?
I would probably do a portion of what they're planning. Like I would do 2 months of Lupron. I would start the Lupron after her menstrual cycle. So she's going to have a thin lining going in. And then instead of a modified natural cycle, I would do a program cycle with estrogen. That would be my MO.
I agree.
I agree. Yeah, that's what I would do too.
Here at Fertility Docs Uncensored, we've spent years answering your toughest fertility questions and walking alongside you on the IVF journey. And now we've taken everything we've learned from helping thousands of patients and from the thoughtful questions you've sent in for us to answer and put it all in one resource, our brand new book, The IVF Blueprint. This book is your step-by-step guide through the entire IVF process, written in the same conversational, down-to-earth style you've come to know from us. Whether you're just starting to explore IVF or you're already in the middle of treatment, the IVF Blueprint is designed to give you the clarity, confidence, and support you need. You can find the IVF Blueprint in print, as an ebook, and as an audiobook with a special conversation from us at the end, wherever books are sold. Links to purchase are also available on our website at fertilitydocsuncensored.com. So if you've been wanting an easy-to-understand, compassionate guide to IVF, pick up the IVF Blueprint today, and let's take this journey together. All right, our next one. How many IUIs do you feel comfortable doing before moving to IVF? My husband and I have done 2 unsuccessful IUI rounds. My husband's semen analysis and IUI samples have been amazing, so no male factor. I have PCOS. I have endo, which I had a laparoscopic surgery for in March. I had 32 sites. My HSG showed no blocked tubes, AMH 2.68. We did both IUIs with letrozole and trigger shot. Our follicle check before both showed 3+ follicles 15 millimeters or larger with an 8 millimeter lining. I was on progesterone after both. We have been trying for almost 2.5 years. What are your thoughts?
Do we have an age on her?
That's what I was
She's
just wondering.
31.
31. Okay. So for her, she's 31, so she does have some wiggle room to do more IUIs. My preferred method of working with patients who want to do IUIs is I'm fairly easygoing with how many we do because a lot of that's going to be shaped by what is their personal comfort level and what is their insurance coverage or lack of insurance coverage dictate. Because if you've got someone who's got 6 cycles of IUI and nothing else, then you're a little bit more likely to push further with IUIs. But the thing that I worry about is the burnout factor with IUIs because people get frustrated with them because you have the eggs growing, the lining's thick, the sperm's there, the timing is perfect, and then it doesn't work because the reproductive system, even in the best case scenario, doesn't work the better part of 70% of each month, if not 75, 80, or a higher percent of not working each month. And so if the rest of us showed up to our jobs with the frequency that the reproductive system works for attaining a pregnancy every month, we would all be fired. And even with IUIs, you're not getting that level of success. In general, best case scenario is like 15-ish percent. The way that I would gauge what's next is how are you feeling? If you are gung ho, we want to do more IUIs, then great. Let's do one or two more. If you are already burning out, let's cut bait and go to something more effective, especially with all the action you've got going on.
It sounds like she has pretty significant endometriosis. Besides the fact I've never heard anybody quote how many
Any
spots they
sense?
had ablated,
Yeah.
that's a little OCD, but that's great, to each their own.
That's a
I've
reflection
never
on the surgeon, not the patient.
Yes,
Just so we're all
exactly.
clear, like this, we're talking about the surgeon here. We are not talking about this patient. This is
Yes.
not. Yes.
Exactly. No, no, no. I'm totally ragging on the surgeon. I mean, it's funny. There's nothing wrong with it. It's just I've never heard of anybody counting how many spots they ablated. But that was actually a very useful comment because that's a lot of ablation. And there's pretty good data to say that the more severe your endometriosis, the more likely you're going to need advanced treatments. If you're at the point where you're like, should I do this or should I just move on to something else? I almost think you should move on to something
Yeah.
else because most importantly, endometriosis in most people are going to recur, and it's going to recur at the same severity at which you had it originally when it was ablated. So if you had severe endometriosis, whenever it recurs, it doesn't just pop up a little bit here. There's a lot of it again, and that rate of recurrence is usually within 6 to 12 months. Give it a few shots of IUI. If we're not pregnant, hop over into IVF. Let's beat the clock. Let's get you pregnant, suppress all that stuff. And then ideally, after you deliver, suppress all that endometriosis as much as we can until you're ready for baby making number 2.
The other advantage is if you do IVF sooner rather than later, even though you may have pretty severe endometriosis, the great news is you should still stimulate really well, hopefully make a lot of eggs and ultimately have a reasonable number of embryos so that you wouldn't have to go back through the whole retrieval process, hopefully more than once if you're lucky.
RMA of New York is a global leader in state-of-the-art reproductive medicine, serving as Division of Reproductive Endocrinology and Infertility at the Icahn School of Medicine at Mount Sinai. Led by an integrated team of physicians and scientists, RMA of New York is renowned for its pioneering research in the field and for delivering high IVF success rates. With locations across Manhattan, Brooklyn, Westchester, and Long Island, RMA of New York has helped thousands to build the families of their dreams for more than 2 decades and counting.
All right, our next one. First of all, thanks so much for your very informative podcast. I've learned a lot. Thank you for listening. I'm 42, AMH 0.15 with superficial endometriosis, one very small endometrioma in each ovary. I have a 2-year-old baby girl from my first cycle of IVF, first retrieval, first transfer. In the past year, I've done 4 rounds of IVF. None are successful. One cycle led to a pregnancy, which stopped at 8 weeks. Hysteroscopy is clean, but they found that I have serious adenomyosis. I've had 9 frozen eggs from when I was 35. My fertility doctor suggested doing a 3-month suppression with Lupron before transfer. I got a second opinion. The doctor said this treatment is not recommended anymore. As I have very few eggs, I want to optimize my chances. Thanks.
I would recommend doing the 3-month suppression because you have endometriosis. And even though you had small endometriomas, If you look at the grading of endometriosis, it puts you in the category of being stage 3 endometriosis, and there's only 4 stages. What that suggests is that endometriosis is deeply infiltrating in you and could have long lasting effects. If you really want to know if that 3 months of Lupron would be beneficial, and I'm thinking more for an embryo transfer, if you thaw those eggs and create embryos, going back to what we were just talking about in the last question, the receptiva assay, you probably want to be tested to see if you have that marker, that BCL6. And if you do, you would benefit at least from 2 months of Lupron leading into your frozen embryo transfer.
I agree with that. I do want to make sure that she understands when she's like, I feel like she's kind of clinging to the superficial endometriosis thing. As you mentioned, you have endometriomas, it doesn't matter the size, and you have adenomyosis. You got a lot of stuff going on there. There's the option of doing 2 to 3 months of Lupron or doing the Receptiva assay. I think if you wanted to avoid having to take a medicine that's going to temporarily make you menopausal for a couple of months, it might be worthwhile to do the Receptiva assay. Also, Lupron or some of the other medications that are used, oftentimes, if you have a positive BCL6 marker, then those medicines are more likely to be covered versus having to cover those out of pocket. So that's another way of thinking about the system. Carrie?
I'm looking through to see if I can find what data might be out there that would have made that other doc say this isn't recommended treatment anymore.
Well,
Because
I
they're
think
taking treatment after laparoscopy, just like throwing in some extra Lupron after laparoscopy is what I think.
I remember when I first came out of fellowship, so this was probably around 2010 or so. It was a big thing at that point that prior to doing egg retrieval, that anybody you suspected endo to do 2 to 3 months of Lupron suppression before going into a stimulation cycle. And that was a pretty hot thing for a couple of years. And it faded out of favor. And that's actually what I'm thinking that doctor's probably referring to, which actually does not apply to embryo transfer.
Right. And I could see where that would definitely not be recommended because a couple months of suppression before a stim means you're not going to get very much embryo or eggs out to make embryos. So, okay. Yeah, in that case, now that I'm off that tangent of, well, where did that data come from? Why did they do that? Yeah, I agree with you guys. I agree with you guys. I think the age of the egg and that component of it is probably the bigger issue. The endometriosis isn't helping, but that's not the main course here. It's the, hey, you've got those other eggs frozen. Let's try those. Let's combine it with the Lupron and see how it goes. I don't think 3 months versus 2 months necessarily makes a difference. If I remember correctly, when they looked at 3 versus 2, 2 is sufficient. 3 did not add benefit to it and does delay by an extra month. And it means you're on a medication for an extra month. It's not always a whole lot of fun to be on. And so I think I would probably do 2 months instead of 3. If I remember correctly, they said that 1 month was insufficient. So you do need the 2, but 3 doesn't benefit.
All right, our next one. Hi, I love the pod and hearing each of your individual responses to get a wider range of opinions. Thank you again. I am 30 years old with an AMH of 0.6 and recently went through 2 rounds of IVF and ended up with 6 blastocysts, 5 euploid, and 1 segmental low-level mosaic. That's awesome.
That's beautiful.
After my retrievals, I did a laparoscopy and hysteroscopy to address pelvic pain and dysfunctional uterine bleeding, along with a believed polyp seen on saline. My surgeon found no polyps, just a thickened lining, but he did find superficial endometriosis on the bladder and rectal area. My REI previously discussed doing 2 months of suppression with Lupron, but I'm wondering if that's necessary at this point, with this likely being stage 1, post-op not for a couple weeks. Would love to hear your thoughts.
It sounds like she had a surgical diagnosis of the endometriosis, which means there's a pretty decent chance that it was ablated at that time.
Treated, yeah.
And so she's got all these gorgeous embryos. If she wants to be super thorough, she can do the Lupron. But I don't know that I would in this case because she just had the treatment and the surgery. She has, I don't want to say extra embryos because I don't ever want to be flippant about the number of embryos, but this is not a case where it
There's
took
one and no, yeah, there's only one.
4 rounds of IVF to get 1 embryo. Even if it was, I still don't think I would necessarily recommend the Lupron because she's had the treatment. Maybe she does a modified natural cycle with letrozole instead of an estrogen stim, but what do you think?
I would say make sure you look at your operative report because we're all thinking about the way that we treat patients, and not every doctor is the same. And there may have been somebody who went in there and looked and said, oh, there's endometriosis there. And maybe because of location of the implants or whatever it may have been, maybe did not actually treat, but they did diagnose. And in that situation, then I would definitely recommend doing the chemical suppression.
That's a good point.
Good point. Yeah, that's right.
We don't all, when I say we, that's in the big like doctor we. And so we don't all do exactly the same thing. And when you have three like-minded individuals, we tend to be like, well, of course you would do this. But
Yeah.
sometimes not everybody does things, because we get operative reports from people and we're like, that's a different way of doing things. So let's do this.
But suffice it to say, I think you have 5 really nice embryos. The mosaic might even result in a normal pregnancy. So you've got a lot to look forward to, I think.
Okay, our next one. I'm a 34-year-old female who struggled to conceive with my first child, who is now 5. I have a history of endometriosis, surgically diagnosed 11 years ago, stage 4, due to a chocolate cyst on my left ovary and adhesions throughout my entire pelvic cavity, including my bowel. After 15 months, we conceived naturally. Since, we've tried for another, medicated with Clomid, letrozole, IUIs time 2, luteal phase support with progesterone suppositories due to breakthrough bleeding. I also was recently diagnosed with Hashimoto's thyroiditis and had a hemithyroidectomy. Also had uterine polypectomy. Husband semen analysis and lifestyle is great. Been tested multiple times. I'm currently trying to decide if excision for suspected return of endometriosis is my best option, or should we try IVF? So
So
I think
was to
you
get
have some options.
Yeah. Goal is to get pregnant, right? So
Right.
she's
The goal is
There's no pain, goal is pregnancy, from what I'm hearing, correct?
correct.
So without the concern for the pain, that's helpful. That means that doing additional surgery probably isn't going to be helpful and may actually stir up problems, because anytime you go in and you operate, there's a higher chance that you'll see something on the ovary that you're going to have to go after, and that's going to inherently damage the ovary, because no matter how amazing the surgeon is, when you're taking a cyst off the ovary, you're taking eggs with it. And she's otherwise young, and so I don't think that's going to benefit her at all. And so the question here is, I think less surgery as one of the options and more IUI versus IVF. And it sounds like she's had 2 kids with relatively minimal drama in terms of getting them. One took longer, but got there. And so now the question is, do you keep going with the cheaper, easier, but less effective, or with the more involved, more expensive, but more effective, particularly in this kind of case where you've got endometriosis with a ton of adhesions? There's a
Mhm.
decent chance that there is scar tissue between the ovaries and the tubes that is impairing mobility, that's making it difficult for the eggs to ovulate and actually connect with the tubes. You can have open tubes that are still damaged and that can't pick up an egg because the ovary is encased in scar tissue. Or maybe there's enough scar tissue around the tubes not to block them, but to impair the ciliary movement, which is the tiny little hairs that move the egg and the sperm and then the resulting embryo down to the uterus. I think, like everything, it's where are you in this? Are you thinking we've got 2 kids, we'd really like a third, or we've got 2 kids and we want not only 3 but 4? And looking towards IVF deals with multiple issues. Like everything, this is such a personalized set of questions to
Yeah.
what are your goals?
Yeah.
It's interesting to be like surgery versus IVF versus ovulation induction IUI versus IVF. If this was 10, 15 years ago, there were people who did back-to-back surgeries on people like you all the time. And most people do not do that anymore. You can ask Abby. It was not uncommon for people to come into our clinic who had had 3, 4, 5, 6
Yes.
surgeries. That just doesn't happen anymore, because we know that, number one, every time we go into that abdomen, not only is there a chance we could help things, but there are things we could seriously harm.
That's
And
what I
and
was thinking
this
of more than anything else. I'm like, I've seen pelvises like that, and I don't want to see another one like that if I can help it. Because I would worry about not only would we not help you, but we'd perforate your
could hurt.
bowel or cut your ureter or damage the abdomen like that. It's like somebody sprayed super glue all over your abdomens. I see absolutely no benefit in going back in laparoscopically at all, period.
Yeah, I think we all agree surgery is not necessarily your next step. It's how if you're thinking about something conservative, doing something like super ovulation with oral plus injectables, something like that, with intrauterine insemination, where we're trying to maximize what's happening inside your body. You've had two spontaneous conceptions in the past. Doing that a few times, 2 to 3, probably wouldn't do more than 3. And if that's not successful, then going on to IVF, unless again, you're trying for 2, 3, 4 more children. And then maybe IVF might be the best thing for us to preserve fertility for the future.
Well, one other thing too, depending on how long it's been since you had surgery, it may really be worthwhile for somebody to do something like an HSG on you. The saline sonogram might work, but I think because of the scarring, it would be harder to see the far end of your fallopian tubes well. Because I worry a little bit over time, maybe you have more adhesions there, and maybe you have more scar tissue, and maybe now you may be at high risk for a tubal pregnancy, which that would not be easy either to go in and take care of surgically if that were to happen. I think it might be worthwhile to have at least a tubal assessment, and that may or may not be a tipping point to guide you in terms of ovulation induction IUI versus if your tubes look somewhat damaged, but maybe not completely occluded, maybe then IVF would be a better option for you.
Next one. 33, husband is 35. I have stage 4 endometriosis, 2 excision surgeries in the past 4 years. Last was in July 2024, 3 months of Lupron, and then tried to conceive for the last 7 months. Currently meeting with RE to discuss next steps. The endo has grown back due to how painfully my periods are, and I've had an endometrioma on both of my ovaries. My endo specialist is concerned with aggressive regrowth and doesn't want to do another surgery without retrieving eggs first. Any recommendations on how to navigate trying to conceive with endo regrowth and starting fertility treatment? Is a long Lupron suppression before egg retrieval a smart idea to help the inflammation? Would a surgery be a good idea before transfer? AMH levels are good, husband sperm is normal. Is IVF recommended or try IUI? Wow, this is great. Puts everything together we've just talked about.
It's like we planted this question or something,
Yeah.
which, by the way, listeners, we did not.
So I would say uh, that, you know, say again, she had how many surgeries? She had two surgeries,
Had two.
and she wants to know if she should do what?
She's trying to balance aggressive regrowth with wanting to get pregnant.
Gotcha. Okay. I would say it depends on how severe your pain is. I've had patients where they have had such severe endometriosis, they've been on Lupron with Advac for a long time, and they're really terrified about getting off of that because they have so much pain. And so, to Carrie's point, sometimes, rarely, I don't like to do it, but sometimes we'll keep people on Lupron and go right into an IVF cycle. And it is a little bit harder to stimulate them. So I would add an extra maybe 75 IUs of medicine depending on what their AMH is. Your AMH is normal. So my feeling would be we probably want to do something like that. I think IVF is definitely the best option for you. I definitely wouldn't say go back and do surgery again based on what we just talked about in the previous question.
I think that the idea of doing an egg retrieval before you do any kind of surgery, because it's possible that pain may force your hand for a surgery, but I think your RE and your surgeon are very correct, and that you want to get those eggs out first because anytime we go in, we can potentially damage those ovaries. And if you've got that bad of endometriosis, there's always the small possibility that we're going to have to take an ovary out in order to help with things. I think getting as many eggs out as you can is a beneficial way to go leading into this in order to help make sure that you're getting your pregnancy goals met.
So the one thing I want to comment on is that um, sometimes I get a little bit worried when people are seeing endometriosis specialists because most of the time these endometriosis specialists are endometriosis surgery specialists. And you're 33. You can't spend the next 18 years having surgery every 2 years for your endometriosis pain. That just is not sustainable. It's not safe. And so, one thing I would think about is potentially trying when you're not trying to conceive and we're really trying to focus on keeping your endometriosis at bay, which pregnancy is one of the best things to suppress endometriosis, is thinking about being on either Lupron with Advac therapy or Orlissa for longer periods of time. And then you're possibly a person that after you're done with childbearing, you need to seriously consider having some of your reproductive organs removed to keep you safe, because the average age of menopause is 51. You can't go through almost the next 20 years only having a surgical remedy to this. What do y'all think about that?
Yeah, I agree. I mean, you're right. I think a lot of times what happens in this situation is if somebody has really severe endometriosis, they hurry up, have all the kids they're going to have, freeze eggs if maybe they don't have children. But ultimately, in order to get rid of endometriosis, unfortunately, at least your ovaries are going to have to come out. I think you'll feel way better. You'll have much more quality in your life to not have that pain all the time and have to worry about that all the time. So I'm never an advocate of pushing somebody to do something they're not comfortable with, but I've seen many people over the years that once they have their ovaries out, they feel like a new person. They feel like they can live their life and do the fun things they want to do without always having to think about the pain and deal with the pain.
And for those people who are listening rather than watching the YouTube videos, when you watch Susan's face as she was describing, you may have to remove reproductive organs, knowing she's talking about ovaries, you can see all of the years of REI training where we preserve the ovaries at all costs. And so you can just see that pain crossing her face as she's saying, like, look, you really may need to think about this, because it is anti everything that we try and do because we live and die by the ovaries. But it is something that you very well may need to consider in order to have a good quality of life, because you not only want to have kids, you want to be able to run around after them and pick up all their messes and change the diapers and do all the things with them. It's kind of a split cause throughout all of it of how do we get you where you want to be, and then to a point where you can enjoy where you are.
That's probably one of the biggest messages for our episode today, is that when you're somebody who's struggling with endometriosis, really sometimes you're going to have to make choices based on, are we talking about baby making right now? Are we talking about baby making in the future? Or are we just trying to control pain, issues with bowel bladder not working right because of deep infiltrating endometriosis and those types of things, and really kind of focusing on what are my immediate goals and what are my future goals, because sometimes those are going to play into each other and you have to sometimes make a bigger game plan than just what's happening in the here and now.
Maybe you even think about freezing eggs and then taking your ovaries out, and then you still have a uterus. You can still carry a pregnancy. You can still create a baby there. But that used to not be an option for women with bad endometriosis, but now that is. So that's something to think about as well.
Agreed.
All right. Well, any last words that you guys want to say or any last thoughts?
No, I think we went through a whole bunch of it. Now, the questions that we get from our listeners are fantastic because they take us down all of these different roads and all of these different
They're hard
nuances that
questions. They're not easy questions either.
no, they're really not. I mean, they're the things that we go to meetings about and we spend a ton of time talking about of what's the best way to handle it. So, A+ questions, we like it.
That's right. So, to our audience, thanks for listening and subscribe to Apple Podcasts to have next Tuesday's episode pop up automatically for you. Also, subscribe to YouTube. That really helps us give reliable information and help as many people as possible.
Visit fertilitydocs.uncensored.com to submit questions and sign up for our email list. Pick up your copy of the IVF Blueprint today at Amazon, Barnes & Noble, Target, or your favorite local bookstore. Check out our Instagram and TikTok for quick hits of fertility tips between episodes.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. Subscribe, sign up for emails, and we'll talk to you soon. Bye.